A recommendation to consider cemented femoral fixation for older patients undergoing total arthroplasty was upgraded to moderate for several reasons. First and foremost, as the number of total arthroplasty procedures increases across the world, so too will the number of periprosthetic fractures. And one of the ways to clearly mitigate that risk is to use cemented fixation. We also had a concern regarding the acceptability of the recommendation. In the United States, for example, over 95% of all hip replacements are performed with cementless femoral fixation, and that's for many reasons. And as a result, we were concerned that given the extensive use of cementless fixation, there may be concern that this recommendation to consider cemented fixation may not have as wide of acceptability as some others. In addition, we've also seen, particularly at academic medical centers, less training for our future orthopedic surgeons on cemented technique, which may also limit the acceptability of this recommendation long term. So due to these several factors, we thought it was important as a work group to upgrade this recommendation from low quality to a moderate strength recommendation. As part of this clinical practice guideline, we looked at exposures. And while many level 1 high quality studies have been conducted comparing the different approaches to total hip arthroplasty, it's very clear in 2024 that there are specific risks and benefits to each approach, and really there is not one singular preferred approach for all patients undergoing total hip arthroplasty. Specifically in the United States, the most common approaches are the posterior approach and the direct anterior approach, and there are unique risks and benefits to each that should be considered for each individual patient. For example, in an anterior approach, there is a higher rate of femoral fracture either during or after the procedure, as well as a higher rate of wound complications. On the contrary, in the posterior approach, there's clearly a higher rate of dislocation. So based on the patient's other risk factors, the unique risk factors for each approach should be considered, and which is why we made a moderate recommendation that each individual patient should be considered when determining an approach. In our clinical practice guideline evaluating the management of osteoarthritis of the hip, we looked at several risk factors for outcomes after total hip arthroplasty. And one of the most common risk factors studied in all of orthopedics is the risk of BMI on outcomes after total hip arthroplasty. And there's been a large body of evidence that we evaluated that clearly shows that there's an association with an increased risk of adverse events after total hip arthroplasty with an increase in BMI. Most particularly and most concerningly, periprosthetic joint infection. And there are several reasons for this, but what's most important is that for patients who have an elevated BMI, they should be counseled on these risks of adverse events after total arthroplasty, and when possible, weight loss education should be provided and recommended to help mitigate this risk. In our clinical practice guideline on the management of osteoarthritis of the hip, we evaluated the role of physical therapy in the non-operative treatment of osteoarthritis of the hip. And we found that the data supports with a moderate recommendation that physical therapy may benefit patients with mild to moderate osteoarthritis, mostly defined by radiographic severity. Patients may have improved function, improved pain, and improved range of motion. However, for patients with end-stage degenerative joint disease or osteoarthritis of the hip, physical therapy may not be as effective due to the mechanical limitations from the disease, which is why our recommendation specifically comments on the role of physical therapy with mild to moderate osteoarthritis and not with severe end-stage osteoarthritis of the hip. In our clinical practice guideline of management of osteoarthritis of the hip, we evaluated the role of both formal physical therapy as well as a home-based exercise program for rehabilitation after total hip arthroplasty. And after a review of the literature, we made a moderate recommendation supporting both. The question then, of course, becomes is when do you recommend formal physical therapy or a home-based exercise program? There are several considerations that will go into that choice. First is access to formal physical therapy. Some patients may not have access to formal physical therapy, which may limit their ability to participate. In addition, there are cost considerations that should come into play for particular patients. Patient preferences and motivation to do the exercises and rehabilitation on their own may also be a factor that should be considered in this choice. Either way, patients can be successfully rehabbed after total hip arthroplasty if they have formal physical therapy or if they do their home exercise rehabilitation program.